Wernicke-Korsakoff syndrome. What is that? Wernicke-Korsakoff syndrome. Korsakoff syndrome. It is basically a type of syndrome which has important four components. Four important components are there in the Wernicke-Korsakoff syndrome. What are those? One is the ocular palsy. One is the ocular palsy. Second is that ataxia. Ataxia. Third one is that amnesia. That means loss of memory, which can be antegrade and which can be retrograde. Retrograde amnesia means loss of previous memory, and antegrade amnesia means there will be no new memory formation. So these are all. And one is the confusion. This amnesia can also be termed as confabulation. Confabulation. Now, why I am discussing here this Wernicke-Korsakoff syndrome? Because this mammillary nuclei and the surrounding thalamus, this mammillary nuclei, this is the mammillary nuclei or mammillary swelling, then it is the tuberal in infundibular stalk, then posterior pituitary, then anterior pituitary, then again tuberal synovium, and this is the almost overall structure of the hypothalamus. You can recognize this thing. And this is the midbrain pons medulla spinal cord. This is the midbrain pons medulla spinal cord, and also this is our thalamus. So what happens? Here is our mammillary nuclei of the hypothalamus. If there will be vitamin B1 deficiency, that means if there will be thiamine deficiency in a patient, then what happens? This nuclei sites, that means in the mammillary nuclei of the hypothalamus, in the dorsomedial nuclei of the thalamus. Third one is the superior colliculi, inferior colliculi, ventral tegmental side of the midbrain. All these were damaged, or infarction will be produced if there will be vitamin B1 deficiency. Vitamin B1 deficiency will lead to damage in these areas, and that will lead to, first, if there is lesion in the mammillary nuclei, that will lead to amnesia, or the confabulation status will produce. If there will be lesion in the superior colliculi, inferior colliculi of the ventral tegmental site of the midbrain, then there will be ataxia will produce. Not only this ataxia, but also the ocular palsy can also be produced by this this damage of the midbrain. And if there will be lesion in the thalamus, then also the not only the confusion, but also the ataxia and overall the amnesia will also be produced. So this is the Wernicke-Korsakoff syndrome. Now, in which patient you can get this type of problem? In case of chronic alcoholics, those who are alcoholic patient, chronic alcoholics, and if this patient or individual will have vitamin B1 deficiency, and if the patient will come with the hypoglycemic status in the emergency department, hypoglycemia, if the patient will present before you with the complaint of the hypoglycemia in the emergency ward, and after getting the history, if you get that patient is chronic alcoholic, and you don't know about its his or vitamin B1 status, whether it is normal or decreased, and to correct this hypoglycemia, if you will give just a conventional 25% dextrose injection in IV, then what happens? This dextrose will eventually convert into the glucose, and this glucose will enter in our brain. Now, this glucose, when enter into in our brain, if there will be decreased vitamin B1 concentration, this glucose only go through the hexose monophosphate pathway or the glycolytic cycle, and produce less amount of ATP. And after, instead of go through the TCA cycle or the citric acid cycle, it will move into the formation of the lactic acid. So this pyruvate will ultimately utilize for the formation of the lactate, and as we all know, this lactate is a acid and it will produce acidotic situation, and this acidotic situation not only the dangerous for our body, but also this lactic acid cannot produce sufficient amount of ATP, and the cell will be destroyed. So infarction will be there. And this chronic alcoholic patient will produce Wernicke-Korsakoff syndrome. That's why it is the dictum or mandate, and you have to remember throughout your life, whenever you will get this chronic alcoholic patient who present in front of you with the complaining of the hypoglycemia, before you will start 25% dextrose, you have to give vitamin B1 injection IV or the thiamine injection IV. Short acting vitamin B1 or thiamine you have to give first, so that there will be least chance of occurrence of this Wernicke-Korsakoff syndrome. That is the clinical importance of this Wernicke-Korsakoff syndrome in our hypothalamus lecture. Now, what are the circuitry of the hypothalamus that we need to know? So first is the fornix. What are the physiological circuitry of the connection of the hypothalamus that we must know from now on? So to understand this thing, we have to first get acquainted with the terminologies. That is the fornix. So first connection is the fornix. This fornix will start from the subiculum or the hippocampal formation. So hippocampal or the subiculum, hippocampus, we can say hippocampal formation up to mammillary, up to the mammillary body of the hypothalamus. This circuitry will be there, a mammillary part of the hypothalamus, and this is the component of the Pf's circuit. This is the first connection. Second important connection is what? This second important connection is known as the stria terminalis. Stria terminalis. So what is that? Stria terminalis. It is the connection between the amygdala. It is the connection between the amygdala up to the mammillary nuclei of the hypothalamus. So stria terminalis is also a component of the Pf's circuit or the memory formation. So together both the fornix and the stria terminalis will utilize for the consolidation of the memory. So these are the relation related with the Pf's circuit, which we were discussing in our physiology of memory lecture. Please go through this lecture to understand the Pf's circuit. Okay. Now third important connection between within the hypothalamus is known as the ventral amygdalofugal pathway. So ventral amygdalofugal pathway. So ventral amygdalofugal pathway is the third connection. It is connected between the amygdala and the hypothalamus. So amygdala and the medial nuclei of the hypothalamus, or mammillary nuclei of the hypothalamus, sorry. Next, fourth important connection between this is known as the number 4. Number 4 is the medial forebrain bundle. Medial forebrain bundle. What is that? Medial forebrain bundle. That also be discussed in our tutorial, which is known as the physiology of learning. Medial forebrain bundle. So medial forebrain bundle is the structure or the axon which will start from the frontoorbital surface of the frontal lobe, and it will pass through the hypothalamus, and eventually it will come into the brainstem. So this is all related with our reward and punishment. So reward and punishment stimulation is basically carried by this medial forebrain bundle, and in case of rewardness, ultimately which neurotransmitter will be released from the mesolimbic pathway, it is the dopamine. And for the punishment, which important neurotransmitter will be released ultimately in the entorhincal cortex, it is the acetylcholine. So all these were discussed in our physiology of learning lecture. Please go through this. Now next important connection is the supraoptic nuclei to the posterior pituitary, where the chemical that are released is the ADH. Next is that paraventricular nuclei to the posterior pituitary, which ultimately released what? Oxytocin. Seventh one is the suprachiasmatic nuclei of the hypothalamus up to the habenular nuclei of the epithalamus, therefrom the pineal body, and ultimately the melatonin will be released. So this pathway is related with our sleep wake cycle. Okay, next important connection is that anteromedial nuclei of the hypothalamus, and it will go through the brainstem, then it will end up into the S sacral 2, 3, 4 at the level of spinal cord. So this is our parasympathetic outflow tract. Okay, ninth important, which is known as the dorsal longitudinal fasciculus, longitudinal fasciculus, which is not correlated with the medial longitudinal fasciculus, which is present between the 6th cranial nerve nuclei and the 3rd cranial nerve nuclei. And the palsy of this medial longitudinal fasciculus will lead to internuclear ophthalmoplegia and also 1.5 syndrome, that will be discussed later. So dorsal longitudinal fasciculus is the pathway of the posterior parasympathetic outflow tract. Okay, now last one is that from the posterior part of the hypothalamus, there's a posterior nuclei of the hypothalamus, which I forgot to mention in the tuberal zone, in the mammillary zone or the posterior zone, where is the posterior nuclei of the hypothalamus or the posterolateral nuclei of the hypothalamus is present, and where from the what sympathetic outflow tract will be originated. And this sympathetic outflow tract will ultimately pass through the brainstem at the dorsal part of the brainstem and eventually go up to the thoracolumbar segment. So thoracolumbar segment T1 to L5. So T1 to L5, L4, L5 segment, our sympathetic outflow tract will be there. It is known as the hypothalamospinal tract. Hypothalamospinal tract. This parasympathetic outflow tract is known as the hypothalamospinal tract. And if it is injured by any way, spinal tract, if it is injured either by the tumor or trauma or the injury, that will lead to Horner syndrome. So Horner syndrome will produce if this tract will paralyzed. So this hypothalamospinal tract is the sympathetic outflow tract which will originate from the posterolateral nuclei of the hypothalamus. So again in the last video slide where we discussed about the tuberal mammillary zone, important nuclei in the posterior segment is known as the posterolateral nuclei or the posterior nuclei of the hypothalamus, where basically our sympathetic outflow tract will be originated. That I really forgot to mention. Please forgive me for this thing. Now move forward. move forward where we are. Yes, this posterolateral nuclei of the hypothalamus, and the dorsal longitudinal fasciculus is the pathway for the parasympathetic outflow tract. Okay, so if we try to mm, depict all these things in a schematic diagram, uh, so how it will be look like, that we must know a little bit. So suppose this is our cerebral cortex, and it will end up into the frontal lobe here. Now from the frontal lobe, what will go down? Tuber cynarium, then infundibulum, then anterior pituitary, then posterior pituitary. Again it will move up. There will be formed the mammillary swelling, and from the mammillary swelling, the brainstem will coming down. So this is midbrain, this is pons, medulla, and spinal cord. Of course, spinal cord. And here, what structure is situated? Over and above the brainstem, and just below and just behind and above the hypothalamus is that thalamus. Now in the, this is the frontal lobe, this is the parietal lobe, this is the occipital lobe, and no fun telling that this is the temporal lobe. And in the temporal lobe, the important structure we know present, that is the amygdala. So amygdala is situated here, and it is the hippocampal formation, and this is the hippocampal formation. Now what we really try to understand here, the connection. So first connection that we mentioned in the last slide, that the fornix. So from the hippocampal formation, or exactly from the subiculum nucleus, subiculum nuclei, the important connection will start arising, that is known as the alveus first, then fimbria, then it will form the fornix and end up into the mammillary body. So mammillary nucleus is present here. No fun telling this thing. So this is the fornix hour. Okay. Next connection that we mentioned in our last slide is the stria terminalis. The stria terminalis will arise from the amygdala and end up into the mammillary body. So this one is the first one. This one is the stria terminalis. Stria terminalis. Okay. Hope you will correlate all these things. Third one is the ventral amygdalofugal pathway. Ventral amygdalofugal pathway. So this is the third one, is the ventral amygdalofugal, as it is centrifugal fashion moving away. So ventral amygdalofugal fiber or pathway, we can say. Okay. Now fourth one is that medial forebrain bundle. This medial forebrain bundle will arise from the frontal lobe. In the fronto-orbital surface, there is one fiber, and there is another fiber from the septal nuclei, and together this thing will connect and form, passing through the hypothalamus and end up into the midbrain area. So this is our medial forebrain bundle, and this is the number 4. So this is related with our reward and punishment behavior. Next important from the supraoptic zone is that supraoptic nuclei and the paraventricular nuclei connection. So hope you can recognize this thing. This is the neurohypophyseal tract. Neurohypophyseal tract. So neurohypophyseal tract from the supraoptic nuclei and the paraventric nuclei of the hypothalamus up to the posterior pituitary. Then from the arcuate nucleus of the hypothalamus, the structure that are coming down is known as the tuberohypophyseal, and from there hypothalamo-hypophyseal portal system. So this is the tuberal nuclei, and from there hypothalamo hypophyseal portal system, and end up into the anterior pituitary, where from the several hormones from the anterior pituitary will be synthesized and released. So this is known as the hypothalamo hypophyseal portal system. As there are two types of capillary, that's why it's known as the portal system. Next important pathway related with this is what? It is the dorsal longitudinal fasciculus. This dorsal longitudinal fasciculus will arise from the supraoptic zone exactly at the anteromedial nuclei of the hypothalamus. So anteromedial nuclei of the hypothalamus, it will start originating the parasympathetic outflow, and it will pass through the midbrain pons and medulla. In the pons, there will be 7th nerve nuclei. In the medulla, there will be 9th nerve nuclei and 10th nerve nuclei. 7th nerve nuclei is the superior salivary nuclei. 9th nerve nuclei is the inferior salivary nuclei. And 10th nerve nuclei is the nucleus ambiguous or the vagus nerve, where from the parasympathetic outflow tract will end up into the sacral segment S234. S234. This is the dorsal longitudinal fasciculus, DLF. Dorsal longitudinal fasciculus. Okay. So this is the next connection. Next important communication is what? It is the hypothalamo-spinal tract, and it will originate from the posterior part of the hypothalamus, that is the posterolateral nuclei of the hypothalamus, and it will end up into the thoracolumbar segment, passing through the dorsal side of the brainstem, which is known as the hypothalamo-spinal tract. Hypothalamo-spinal tract, and this hypothalamo-spinal tract is the sympathetic outflow tract. Okay. So these are the connection. Is it very difficult? I hope it is not. After learning this video, all this connection, communication, neuroanatomy, and the physiological circuitry of the hypothalamus will be so easy to you. And still, if you have any problem related with this important aspect of the physiology, please do comment and share your suggestion at the end of this video. I hope you will enjoy this tutorial session of the hypothalamus. Thank you.